basically give us a quick rundown of yourself, where you're working, and how you're involved with this.
Absolutely. No, it's a pleasure being here. My name is Bhavik Shah. I'm a urologist up here in the United States, in Georgia. I specialize in prosthetic surgery. I'm the director of men's health here in our in the program we have running here. My passion's in prostate cancer survivorship, helping patients recover from their surgery and prosthetics, implants, and so we frequently use implant surgery to help patients get through their recovery process. And fortunately, I have the pleasure of working with Dr. Venter here and traveling down to South Africa frequently to help expand some of those teachings.
Great stuff. I'm Dr. Johan Venter. I'm a private urologist working at Pretoria East Hospital in South Africa. It's in Pretoria. We are not really super specialized here in Pretoria, so we deal with basically all urology conditions. But I must say I have real interest in prostate cancer, robotic surgery, and of course survivorship of prostate cancer. Deal a lot with implants and our incontinence in these patients, and really appreciate the help from abroad.
Awesome.
Okay, I think I should just start this conversation with a quick question. And it's just for the layman people to basically understand prostate cancer and erectile dysfunction. And the question is basically that many prostate cancer patients and survivors from prostate cancer suffer from erectile dysfunction. In layman's terms, how can you explain to us how prostate cancer and the treatment thereof can lead to erectile dysfunction?
Yeah, I mean, that's a great question, right? So remember, prostate cancer treatments, surgery, radiation, in general, it's impacting the prostate tissue. That prostate tissue is sitting by the bladder, and what runs around the prostate tissue are the nerves for your erections, right? So the number one takeaway is, remember, if you're removing the prostate tissue, you are at the very least impacting and either teasing off the nerves, we call that a nerve spare, or removing the nerves in some cases in more severe prostate cancer cases. And so if you're removing the nerves for your erections, then accordingly, you're going to have worsened erectile dysfunction. That's one thing. Another aspect of it is that even if you're just teasing off the nerves, you're causing something called neuropraxia, where you're stunning the nerves. And data shows it can take up to 2 years for that stunning to go away. Well, during that time, you're not getting regular erections. And so if you're not getting regular erections, your penis is like any other muscle in your body, right? If you've ever seen a paraplegic, a person that can't walk because they have a nerve injury to their spine, and so their legs don't work. Well, in those cases, they're not getting nerve stimulation to their legs. And when they're not getting nerve stimulation to their legs, if you've ever seen their legs are very thin. They have very little muscle in their legs. Well, the penis is the same way. If there's not regular blood flow and regular nerve stimulation, then what's going to happen is you're going to get something similar. We call it disuse atrophy. Atrophy as in a loss of muscle from not using it. So when they say if you don't use it, you lose it, that's exactly the case here, right? Not having those regular morning erections is causing the penis to atrophy, shrink. The problem with that shrinkage is when the erectile bodies shrink, they lose their ability to expand. Radiation also impacts that, causes them to lose what we call loss of elasticity. Instead of being like a balloon stretching, they become almost like a tin can. They can't stretch. That's a problem as well. That scar tissue formation, that loss of elasticity and stretching, what that does is leads to something called venous occlusive disease. The erectile bodies, the erection, your penis's job when you get an erection is to stretch, and when it stretches, it squeezes the veins on the outside shut. If it can't stretch, it can't squeeze those veins shut. And if it can't squeeze those veins shut, the blood that goes into the penis, allowed to have an erection leaks right back out into your blood system and you can't keep the erection. During those 2 years of neuropraxia, if you're not getting regular erections, you start getting that scar tissue formation, that loss of elasticity and stretching ability, and eventual venous leak. Venous leak or venous occlusive disease is a permanent condition that does not reverse once you get it. So 3 reasons why patients that have prostate cancer treatment get erectile dysfunction. Number 1, loss of nerves, right? The surgery itself or even the radiation is impacting the nerves sitting around the prostate. Number 2, impact in the blood flow. Radiation destroys blood vessels. Surgery, you're tying off blood vessels, right? So you're decreasing blood flow to that area. Number 3, long-term venous occlusive disease. Those veins are not getting compressed anymore because the penis has lost its ability to expand, and that leads to a permanent condition called venous occlusive disease. And oftentimes when you have venous occlusive disease, your next best and sometimes only option is a surgery like a penile implant.
I think that's a great explanation. I think I've seen a lot of patients, and many of my patients actually believe that the prostate is an essential organ to having an erection. And I think it's important that they know that the prostate has got nothing to do with your erections. It's the damage we do in order to get rid of the cancer that causes the erectile dysfunction by affecting the nearby structures.
Yeah. And you know, the answer, you know, one of the conversations we typically have is then why did we even bother to do the treatment? And just remember, it's still important to treat your prostate cancer, right? The takeaway point is not just don't treat the prostate cancer. Because if you die of prostate cancer, then your erections, you're not going to have any hope in having erections anyway, right? The goal is to treat the prostate cancer, do what you need to do, but just know that there's still hope after that. We can still fix it. We can treat, you know, whether it takes medical therapy or conservative therapy injections or surgery to do it, we can still do it. There is hope out there, but just we're not telling you to neglect the cancer. We're just telling you that treating the cancer may have repercussions, and just if you see the right people, have the right treatments, we can still overcome it.
I usually tell my patients there's 3 priorities in this whole thing with prostate cancer. And I start off by saying, you came to see me with prostate cancer. That is the thing that's going to kill you if we do not manage the disease. So getting rid of the cancer will be your first priority, irrespective of the other 2. The second one will be continence, because I think that has got a major impact on normal quality of life on a daily basis. So that will be my second priority, and erectile function will be my third. And it's important to say it's third and not last. It's a very, very important factor in quality of life at the end of the day. But I work according to those 3 priorities with my patients.
Yeah, I mean, I think that's a great way to phrase it. I think priority number 1, get rid of the cancer. Know that it is possible that you have repercussions that impact your urination and your erections. Know that we will address it and we will manage it and take care of it and work with you to try to get your quality of life back to where it was before.
Excellent. I think another factor that we need to talk about the treatments, how the treatments can impact erectile dysfunction is we need to talk about hormonal treatment, because that's also one big, how can I put it, factor in the treatment of some of our patients, especially the guys with advanced disease or with metastatic disease. And I think it's important for those patients to realize that normal erections is going to be a problem. If you don't have testosterone, it's actually a prerequisite to all of this.
Yeah, and that's a good point. So if you're talking about prostate disease, right, one of the hallmark treatments is going to be androgen deprivation therapy, right? So we're basically cutting off your hormones, your testosterone, which doesn't necessarily directly impact your erections, but it does indirectly impact it. There is a connection between your sex drive, your desire to want to have sex, and obviously your ability to have sex. So it is. So if you're on treatments that decrease your testosterone, you're automatically going to have some decrease in your erections. So it does play a role. It's important to keep in mind, again, the hormone treatment or the treatments for your prostate cancer are still an essential part of your treatment. If you look at every guideline out there, it doesn't say just stop treating the prostate cancer. What it says is, okay, try treating the erections in other ways, right? Because you're already getting less stimulation from your brain to your from your testicle, then to your brain, and then to the penis. And so we got to find other ways around that. And erections, whatever it takes, there are ways to try to improve those erections. And again, there I wouldn't say 3 treatments, 4 treatments, 4 reasons why you're not getting good erections. We talked about the veins, we talked about the nerves, we talked about the arteries, and then also the hormones, which Dr. Venter mentioned. Those are really the 4 reasons why you're not getting great erections. But again, the takeaway point is, look, we'll fix it. We can get around it. We'll work around it. Just don't neglect your prostate cancer, and work with experts such as Dr. Venter to get to where you need to be as far as your quality of life.
I was an opinion on it's a two-faced question, but let me start off by saying that men in South Africa face a reality where access to herbal solutions and even prescription medication is available to them through unregulated channels. The reason for this is the economic situation in South Africa at the moment, and the fact that our medical funders don't necessarily pay for these treatments. So these guys will try anything, and then they end up taking uncontrolled substances or herbal medications for erectile dysfunction. And what are the risks involved with this?
Yeah, that's a great question. There's some herbal medications that are not well studied, right? And there's a little bit of data that shows maybe they help. Things like I think like horny goatweed and things like that. They're just like herbs. And again, they're not well studied, so you don't know what the side effects are going to be. Then you have testosterone supplements that you can get free in the streets. And you got to be cautious. Remember, if you already have prostate cancer, now you're taking unregulated substances that may have a hormone like testosterone that could be stimulating prostate cancer growth. You may be putting yourself in harm's way. The third thing is there was actually a recent study that looked at these over-the-counter or herbal supplements. They looked at the contents written on them, and then they would take 5 of each substance and test them. And what they learned is none of them were consistent. Even if you took 5 of the exact same over-the-counter substance and tested them, there was no consistency in what was actually in them. And so the takeaway point is it's unregulated. So anything can be in them. And so because anything can be in them, you don't know what you're putting into your body. The difference between a regulated and unregulated substance is if it's regulated, it's tested, and we know exactly what's in there. We know how it works, why it works, and if it works. We also know the side effects. We know how it may impact you. In the unregulated substance, it's a free-for-all, right? It may work, it may not work. We don't know what's in it. And that can be scary at times, especially when we talk about substances that may be enhancing things like your testosterone. And remember, that can impact your risk of prostate cancer.
Absolutely. I've got no questions. I don't know if any of the other panel has got anything, but I think this was a great discussion. I'd like to have it again with you.
Yes, absolutely. And I look forward to seeing you again in person in September.
Great stuff. Have a nice day.
Okay.